I mean, it was not really much to offer by way of treatment. But now we have newer antifibrotic drugs which can make a difference if the diagnosis is made in right time. And how do we diagnose ILD? I mean, what all the tools in our armamentarium? We have history, of course. We have the PFT, which will tell you whether it's a restrictive lung disease or not. You have radiology comprising mainly of chest X-ray and HRCT. Chest X-ray would tell you a lot of things, but pretty late in the disease. HRCT is what we are going to discuss today evening. BAL could be useful in couple of ILDs like lymphocytic interstitial pneumonia, but not necessarily anything else. Biopsy is the gold standard, but getting a lung biopsy is not very easy. So if somehow we can give a clue to the diagnosis without doing a biopsy, that would be great useful to clinician. And of course, there is genetic testing, which kind of confirms the diagnosis and prognosis. But there is some pathological basis of the radiology we do. Every disease has a pathological spectrum. We are radiologists, we image the tissue or organ, and then we interpret the pathological findings as radiology. This is the fundamental basis of radiology. There is no question about it. And when we are talking about lung, what is lung? Lung is basically lots of air spaces which is supported by some interstitial kind of bands. So, I mean, there is a limited repertoire of response to injury to lung. Any insult to lung with lead to inflammation, which would be followed by either recovery and resolution or development of fibrosis. And it is this kind of spectrum of inflammation, resolution, fibrosis, its distribution, its location, and its kind of evolution, which helps us in identifying the radiology spectrum or the radiology features which we are so used to in diagnosing ILD. This we will see in the cases as we go ahead. So diffuse lung disease, it could be fibrosing, it could be non-fibrosing. Fibrosing, commonly it is usual interstitial pneumonia or UIP, probable UIP, and alternate diagnosis or inconsistent with UIP. There is a separate bucket called NSIP. NSIP doesn't really feature in the classification of the American Thoracic Society, but we are so used to talking about NSIP that it should be mentioned. And I will come when we discuss cases, how do we differentiate between all these. And then there is a separate bucket of three big diseases, and which are sarcoidosis, hypersensitivity pneumonitis, and smoking related diseases. Apart from that, there are non-fibrosing diffuse lung diseases, which I will not be talking about today. So today's topic would be restricted about diffuse lung disease, cases showing various spectra, and probably in the end, we'll talk about these three monsters which I just mentioned. First comes first, what is fibrosing ILD characterized by? Three things: reticular opacities, traction bronchiectasis, with or without honeycombing. So, if you see reticular opacities and you see traction bronchiectasis, be sure you are dealing with a fibrosing lung disease. Don't even bother about honeycombing at first stage. And if, as a young radiologist, on an HRCT scan, you can pick up fibrosing lung disease, half the battle is won. So this is very important. Then we go on whether there is honeycombing, not honeycombing, what are the other features, and how we proceed. So now I'll be showing you some cases there will be some toggle because my cases are in my Horus. So I'll keep toggling between PowerPoint and Horus, but bear with me. So can everyone see? Somebody show me a hand or something to confirm or speak.
Yes, sir, we can see, sir.
Okay, thank you so
Can
much.
you try scrolling it, sir, once?
Yeah, I'm scrolling now.
Yeah, that works, sir. Yes, sir.
Yeah. So as you see, this is a 75-year-old gentleman came in with shortness of breath, and I am starting from the upper lobes. As I go down, I definitely see there is a lot of reticular opacities. I also spot some traction bronchiectasis like here, and then I suspect, okay, I'm seeing probably honeycombing. And as I go down, I notice that, all these findings are increasing till I come to the lower lobes when these findings are basically profound with lots and lots of honeycombing. What is important to note is I do not see any areas of ground glass opacification. I do not see any nodule, and I do not see any other specific abnormality. And this is why this is a classic usual interstitial pneumonia. I am seeing reticular opacities, I am seeing bronchiectasis, traction bronchiectasis that is, and I am seeing honeycombing. I am seeing what we call an apicobasal gradient. The findings are more common in the predominant in the lower lobes. Absence of anything else. This is the classic UIP, right? So this is what it is. It's a classic UIP, all these features. And the bottom three, subpleural and basal predominant, spatial and temporal heterogeneity. I would like to spend half a minute on this. What is spatial and temporal heterogeneity? It means that the disease is evolving and is in different stages of evolution in different parts of the lung. It is not that the disease in upper lobe and disease in the lower lobe are at the same stage. So they are kind of, it shows that there is spatially separated. And absence of anything else is very important, particularly, when you go on to differentiate a classic UIP with something else. If it is not UIP, if some other underlying disease is there which is causing this pattern, so absence of anything else helps us to differentiate that. So this is one slide. I mean, a lot of junior colleagues ask me to differentiate between emphysema, cystic bronchiectasis, and honeycombing. And I always kind of try and show this slide. So here you see on this image, there are very, very thin septae, peripherally placed air lobules, almost of the same size, right? And you don't really see any more cysts on top of this. I do not see any associated reticular opacities. I do not see any associated traction bronchiectasis, right? Come to this image, you see small, slightly thick walled lesions which are clustered together. Again, I do not see any reticular opacities. This is bronchiectasis. A profound example of cystic bronchiectasis where you see everything in form of cysts in the left lower lobe, which is associated with evident loss of volume if you compare with the right side. You would wonder if this is not interstitial lung disease. But please remember, interstitial lung disease is never unilateral. So this is most likely a post-infective cystic bronchiectasis, whereas the image at the bottom is see shows traction bronchiectasis. You see this reticular opacities, very dirty and honeycombing. Honeycombing is basically cystic structures placed peripherally which are in 2 to 3 layers, more than 2 layers. That is when we call that honeycombing. So for junior colleagues, first year residents, very important to differentiate between emphysema, cystic bronchiectasis, and honeycombing. Next case, if I show you, so again I'm scrolling from up down. You see reticular opacities. You are seeing traction bronchiectasis. You come here, you are almost sure of traction bronchiectasis. You keep going further down, you start suspecting you are seeing honeycombing, but you're also seeing a lot of ground glassing out here, which you did not see in the previous case. And as I come down, I am 100% sure that there is honeycombing as well. So there is honeycombing, there is traction bronchiectasis, and there are areas of ground glassing. So what do I call this? At this age, because there is honeycombing, there is only one diagnosis, UIP, and the ground glass opacities can be explained by an episode of acute exacerbation or a superimposed infection. So don't make the mistake that if you see honeycombing and you see ground glass opacities, then it is not UIP. It is not like that. If you see honeycombing, UIP is the first thing which comes to your mind. The second thought which should come to your mind is whether this is idiopathic pulmonary fibrosis or there is some underlying pathology which has led to this, right? And if that is also not there, then it is possible it represents an episode of acute exacerbation or there is superimposed infection. So this is the table classically we are all used to see American Thoracic Society kind of classification, UIP, and it lists very clearly the criteria which I have highlighted earlier in a bigger slide. So next we come to this case, which is an 85-year-old lady, and she has come with shortness of breath. No other history is forthcoming. And when I show you this case, so again I'm scrolling from top and I definitely think there are some reticular opacities. I hope everybody can appreciate that. And I keep scrolling down. I am still seeing reticular opacities. And I see some traction bronchioliectasis like here. I hope you can spot this. Right? But I'm going down. There is traction bronchiectasis. However, I have failed to spot any clear-cut honeycombing. So this is slightly different. We have an old person with shortness of breath. We have reticular opacities. We have traction bronchiectasis for sure, but no conclusive evidence of honeycombing. And whenever you are in a doubt between traction bronchiectasis and honeycombing, these reconstructive images are very, very useful, MPRs, both coronals as well as sagittals, because then they kind of lay down that dilated bronchiole in kind of linearity, and you can appreciate that, oh, okay, this is traction bronchiectasis. So there is no honeycombing. I really do not see any honeycombing here. So this, and there is no consolidation, there is no ground glassing, there is no nodule. So this falls into that category of probable UIP, in which everything is there, but honeycombing is not there. You could argue with me if it is an early ILD, if you should label it as differently. But I would say that ILD is definite because of presence of reticular opacities and traction bronchiectasis. And in an 85-year-old lady, it is likely that it is probable UIP rather than anything else. There is one more case to show you in this series. So pardon me this toggling because I'm working on one laptop. So there is no way that I can avoid going back and forth between the PPT and Horus. So I'm scrolling from down and I'm going up. Again, I see some reticular opacities, traction bronchiectasis, areas of ground glass opacities. That is different than the previous case, right? But again, I do not see any honeycombing. That would be fair to say. I think you would agree. Although this is more like a didactic lecture rather than a case discussion because I really can't hear anything from you guys. But so again, as I said, reticular opacities, traction bronchiectasis, no honeycombing, areas of ground glass opacities, and this is what perfectly fits into the definition of probable UIP. In fact, the American Thoracic Society mentions that mild GGOs are allowed in this category. So this is the spectrum you deal with probable UIP cases. And honestly, I'm telling you, experience has taught me that there is definite kind of age factor which we should keep in mind while making this diagnosis. So if the patient is above 70 years, I mean, you should think more in terms of UIP than anything else, either probable UIP or definite UIP. It is very unlikely above 70 years, and history wise, if the patient is a smoker, that the diagnosis would be something else. So, when you have some confusion in your mind, these are the things you keep in mind and mention in the report. Pick up the phone, talk to your clinician, tell them this is why I feel this is this, so that he can correlate whatever is going on his mind and then decide whether he wants a follow up or he wants to go for a biopsy straight away. But this is how the probable UIV bucket would look. As I said, may have mild GGOs, so that is kind of those two cases exemplified perfectly what is probable UIP. So this is another case. Now this is again 78-year-old lady. All such patients present with shortness of breath and seldom give any other history. So again, I'm scrolling down and I see some subtle reticular opacities in the subpleural region, more on the right side. Some here as well. And then as I go lower down, am almost certain that yeah, I'm seeing reticular opacities, maybe bit of traction bronchiectasis as seen out here. I hope you can see the arrow. And definitely no honeycombing. So what do I do with this case? I mean, the findings are very subtle, but there is definitely two findings of fibrosing diffuse lung disease are there. There is nothing else. Maybe there is some pleural thickening out here on the left side. So this is a slightly confusing thing. You could argue with me that I should call it probable UIP because the patient is 78 years of age. But somehow I do not see that the fibrosing lung disease is significant to be called probable UIP. So I would like to keep it in that bucket of indeterminate for UIP, which really consists of two entities. First is something like this, which is like early ILD, and second is like the findings are a totally mishmash. You feel that I have seen reticular opacities, but I am not sure about traction bronchiectasis. That is where, when truly unclassifiable images, then those cases you should put in indeterminate for UIP and definitely advise a follow up after 3 months to 6 months. So this category indeterminate for UIP, subpleural basal predominant, subtle reticulation, may have mild GGO, which is the early UIP pattern, or CT features and distribution of lung fibrosis that do not suggest any specific etiology, truly indeterminate. So this is that one basket in which you can put things which you are not sure, but don't put something which goes into the. So this is about this. And now we have this very interesting case. You will see change of spectrum. This is a 44 years lady who has come with shortness of breath, young patient, and where is my arrows gone? Are you able to see the screen, or has the sharing stopped?
Yes, sir, we are. We can see the case 6 right now.
Okay, good. So this, as I said, 44-year-old lady, uh, and I am again scrolling from top to below. Nothing much, but what am I seeing here? I am seeing subtle reticulation, slight haziness in the subpleural region, which as I go down increases, and I am almost certain now that it is there, to the extent that now I am seeing a distinct opacity in subpleural region with very clear subpleural sparing. It is also seen on the left side, though probably it is not as kind of well seen here than it is seen on the right side. and I see traction bronchiectasis. I'm sure there is traction bronchiectasis. You would be sure as well, right? So I have seen some faint ground glass opacities. I have seen reticular opacities in the peripheral regions of both lungs with distinct subpleural sparing. I have seen traction bronchiectasis. I have not seen any nodules. I have not seen any honeycombing. It's a 44-year-old lady. So, what is this? So, please remember, paint this picture in your mind. Whenever you see this dilation and traction bronchiectasis in periphery with subpleural sparing, it is the classic NSIP pattern. I mean, there is nothing else to NSIP but this. Everybody feels that NSIP is something which you cannot classify, so it becomes non-specific interstitial lung disease. It's a very, very specific entity, and it typically looks like this. And a careful radiologist would note while scrolling down that there is, in addition, a dilated esophagus, which is a sign of scleroderma, and therefore we know there is an underlying connective tissue disease, and NSIP is common in connective tissue disease, particularly in the young. So all this, I mean, it is as good as a biopsy diagnosis. I would call up my pulmonologist and tell them this is NSIP. You don't really need to do a biopsy. It is that classic a finding. But again, as I said, it is specific. Don't kind of make it a waste paper basket. And which care should be taken before labeling a case as NSIP. So you have reticular opacities, traction bronchiectasis, you may have, you may not have. In this case, we did have. There is definitely no honeycombing. There is subpleural sparing, and there is spatial and temporal homogeneity. You could see that the findings were almost similar in the both sides with subpleural sparing. It is not that there were findings in the central distribution and there were findings in the peripheral distribution. They are predominantly peripheral, and GGOs might be there. Again, just to emphasize, it is not a waste paper basket. It is rarely idiopathic. Most commonly, you will have history of connective tissue disease or some drug toxicity. Age is an important factor, usually seen in the younger age group, and by young, I specifically mean below 50, 55. Right? It is rare to see this disease as NSIP because ILD also evolves. If something starts as NSIP in CTD and the patient survives for 2 to 3 decades beyond diagnosis, it is possible the disease also progresses and evolves into something else. So it is rare to find NSIP, say, above 70 years of age. And extremely, extremely rare if there is no history of connective tissue disease or any drug therapy. So that is where you may take a breath. I will also take a breath and probably a swig of water before I show you the next case. And I only hope that I have been able to put across the concept of UIP, probable UIP, indeterminate for UIP, and NSIP clearly with the suitable examples I have shown by these cases. And this case, a 57-year-old lady, known mixed connective tissue disorder. Thankfully, we have history and worsening shortness of breath. And now, let me show you the So again, from top to bottom, reticular opacities for sure in peripheral distribution, traction bronchiectasis for sure, some ground glassing out here, definite traction bronchiectasis. You can see it here. More findings as we go down. And there is ground glassing in the lower lobes. Along with traction bronchiectasis, the world would differ whether I'm calling this traction bronchiectasis or I'm calling this honeycombing. But you may satisfy yourself with these reconstructions. So these are all really traction bronchiectasis. These are not honeycombing. You can see extending, and there are no really layers of cysts to be seen. So we have a question to answer. We have a young patient, 57 years old, uh, who is a known case of mixed connective tissue disorder. Even before seeing the scan, because there is history, I'm looking for NSIP. My mind is already biased. But when I'm seeing the case, I'm finding classic features of fibrosing lung disease like reticular opacities and traction bronchiectasis with some ground glass opacities, no honeycombing, and I am seeing, if you remember, I'm seeing a picobasal gradient. The findings are definitely more in the lower lobes than they are in the upper lobes. So, am I still inclined to call it NSIP? Or I would probably call it probable UIP. So, that is the question in my mind. And this is a case in which I will ring up the physician. I will ask him what he is thinking, and I will frankly communicate my state of mind to him, and I will advise him that either you should go in for a follow up or this is a right candidate to get a biopsy done, because I am not sure whether this is probable UIP or because history of connective tissue disorder, it is NSIP. Had there been no history of connective tissue disease, I would have called it probable UIP. But there is history, therefore, I am a bit skeptical this could be NSIP, and the treatment differs, so it could have implications. So, this is an important case to remember, and I have borrowed this slide from the master, Dr. Ravin Jankaria. Whenever we have this question of probable UIP or NSIP, then first thing is we look at age. If it is age is less than 50 years, it goes in favor of NSIP. If age is 50 to 70 years, then we think, what is it? Now, this case was 57. If there is history of CTD or drugs, probably towards NSIP. If the patient is smoker, probable UIP. If neither, we either go for a multidisciplinary meeting or biopsy. In my mind, I am more inclined towards probable UIP in this case than NSIP. So I would advise a biopsy. But this is the kind of path to be followed. It is not very objective. Lots of things in medicine and radiology are subjective. So even if you advise follow up, advise with a word of caution. And this is absolutely probably the right case for biopsy. A lot has been said about UIP and IPF. I mean, people use this term interchangeably. As you can see in this slide, they may look alike, but they are not really the same. So the difference is that UIP is a pattern which may be seen with multiple diseases. Idiopathic pulmonary fibrosis is a syndrome which is basically idiopathic. The moment we see that UIP pattern is because of connective tissue disorder, we call it CTTILD. If it is because of sarcoid, we call it sarcoid UIP. If we do not find any cause behind that, it is only then and only then we call it IPF or idiopathic pulmonary fibrosis. So, just to make the distinction clear, as we move forward to our next case, so a gentleman in the 70s, shortness of breath, same findings, reticulation, traction bronchiectasis, going down, the findings are increasing, and then there is honeycombing. And if I were to show you the coroner, somebody has already noticed probably that the esophagus is as dilated as a trachea. And if I show you this image, you would agree that there is definite fibrosing lung disease. The findings are more in the lower lobes, and there is a zone of demarcation between normal lung and the diseased lung is very sharp, something which we call the straight edge sign, and it is typically seen in connective tissue disease ILD. So, just to tell you that if you see this spectrum, even if you don't see a dilated esophagus, which is so obvious in this case, then do suspect an underlying connective tissue disease. Otherwise, this is a UIP pattern. Next case is a 64-year-old lady, shortness of breath, again reticulations, traction bronchiectasis. Funnily, there is involvement of the anterior lung out here in the upper zone itself. So my mind is already made. I am dealing with interstitial lung disease, and as I go down, I start to see a honeycombing, unquestionable honeycombing. And to my surprise, this is lots and lots of honeycombing. I mean, it was not when I was scrolling through the upper lobes, I did not expect that I will see so much honeycombing at the lung basis. A The term we use for this kind of honeycombing is exuberant honeycombing. Again, this is a feature which is seen more often than not in connective tissue ILD. So I have shown you two cases which suggest, and again you see the dilated esophagus as well, which suggest connective tissue ILD. And the aim of showing you these two cases is that as a radiologist, it is my duty not to label everything as UIP and put it in the bucket of idiopathic pulmonary fibrosis. It is my duty to look for a cause. If there is, I can find out any underlying disease. I can then correctly classify whether it is IPF or it is because of something else. And it has got prognostic significance because the line of management changes. So that is important. So this is again exuberant honeycombing is also a sign of CTD ILD. One different case I need to show you is this 48-year-old lady, known Jogren syndrome, makes my life so much easier once the history is known. Top to bottom. Now look at the trachea and look at the lungs. So you would see that there is, some kind of haziness in the lungs as compared to the attenuation inside the trachea. So this is like air, but this is not really kind of air. There is a subtle ground glassing. So I will call this a subtle ground glassing. That is what I have made up my mind. And as I go down, I see the cystic structure, another cyst, another cyst. And these cysts help me to make my mind sure that, okay, there is subtle ground glassing because these are definitely darker than these areas. So I have subtle ground glassing throughout the lungs without anything, and I have got multiple small cysts. It's a female patient. She's only 48 years old. She's a known case of Sjogren's syndrome. These findings are attributable to only one thing, which is lymphocytic interstitial pneumonia. It's an absolutely classic case. And it should have been called LIP, even if there is no history of Sjogren's. But the fact that there was history of Sjogren's, that makes me extremely comfortable to call it. But these are the absolute classic findings: subtle subtle ground glassing and presence of small cysts in a middle-aged female patient. So do remember this picture, LIP. I mean, it is rare, but you could come across it once in a while. So just to summarize the slide, ILD in CTD, there are four signs. Anterior upper lobe sign, in which you will findings in the anterior upper lobe. Remember, classically ILD we say is more in the lower lobes. There's a four corner sign. When the corners of both lungs are involved, they show honeycombing. Exuberant honeycombing, I told you, and straight edge sign also, I told you. And while looking at each scan, you should look at esophageal involvement, pericardial involvement, bone and joint abnormalities. Remember, very common in RA, and soft tissue calcification, as well as you could add lymph nodes to this list. Even though HRCT are plain scans, but you should always try to look at the mediastinal window for lymph nodes. They could give you a clue. So this is the about ILD in CTD. You should be mindful of this. And this slide, I'm grateful to Dr. Anmol. He shared with this, and you can see the signs: the anterior upper lobe sign, the exuberant honeycombing, as well as the straight edge sign. I thought it would be useful to put them all on one slide and drive home the point I'm trying to make. Next, so we are done with this as well, and we come to the next series of things. This is a 39-year-old lady who has come with shortness of breath, and I tell you, an absolutely dramatic scan. So I scroll, and the first thing hit my eyes is, oh my God, what is this? These are almost destroyed lungs because of honeycombing. Or is it something else? There is traction bronchiectasis, lots of it. There is honeycombing. There are areas of, what should I call them? Not kind of consolidation, but probably parenchymal fibrosis. One thing which comes to mind while I'm scrolling down is that the disease was so much more predominant in the upper lobes than it is in the lower lobes. Till now, I've shown you so many cases of diffuse lung disease, ILDs, where the disease is so profoundly more in the lower lobes. But in this case, I mean, we see it so much more in the upper lobes, which is totally different, right? And might as well have look at the mediastinal window. I mean, this is not really the usual ILD I'm seeing. Then I do spot that, okay, it's not a contrast scan, but I mean, this, what is this? This is a lymph node. There are more lymph nodes here, and there are lymph nodes here as well. Everywhere there are lots of lymph nodes. So you see, whenever you see this disease, which is more marked in the upper lobes than the lower lobes, and it's a kind of confusing spectrum of fibrosing lung disease, parenchymal fibrosis, lots of lymphadenopathy, and something and nodules maybe, then you are sure you are dealing with sarcoidosis. Sarcoidosis is a great masquerader. I'm telling you, always keep it in mind. It could present as a consolidative disease, it could present an ILD, it could present as a nodular disease, or a combination of all these. So, this was a classic sarcoid, which was very advanced. And to drive home the point, I need to show you one more case, which is also a similarly aged 38-year-old man who has come with cough and fever. What happened there? So when I scroll this, I am seeing parenchymal areas, confluent areas of parenchymal fibrosis in both lungs, in the upper lobes, with thickening of the peribronchovascular interstitium, some nodular densities, but predominantly the disease is perihilar with thickening of peribronchovascular interstitium. This is the other spectrum of sarcoidosis. Believe me, it cannot be anything else. You don't think in terms of tuberculosis with such kind of extensive disease. Of course, that will be in the differential, but I mean, you could be almost sure that this is sarcoidosis. Let us have a look at the lung window. I don't even remember. Yeah, but there are lots and lots of lymph nodes. See, confluent lymph nodes, bulky, no calcification. There's also a classic sarcoid. So be mindful of sarcoidosis. Never forget sarcoid. Whenever you see a chest CT, never forget sarcoidosis. In India, you cannot afford to forget tuberculosis, but add sarcoid to that list as well. And next case is a 48-year-old lady presented with cough. Now, this is interesting, slightly different. Just pay attention. Reticular opacities in the periphery, traction bronchiectasis, first class, no problem. I am dealing with a fibrosing lung disease. I have made up my mind. There is ground glassing. Sometimes I feel there are subtle, fine, fluffy nodules. And wow, what is this? A dark area. More such areas. More such areas. All this I have not seen earlier in so many cases of fibrosing lung disease. So this should prompt me to think differently. And ideally, before calling them areas of trapping, I should show you expiratory scans, which unfortunately I don't have. But on the basis of suspicion of air trapping associated with usual features of fibrosing lung disease, I would think in terms of chronic hypersensitivity pneumonitis and correlate with expiratory scans and proceed further. So this is the word of caution. When I find findings like this, I would just not think in terms of NSIP or probable UIP. I will think, okay, maybe this is something else, and we need to rule out chronic hypersensitivity in pneumonitis. It is again a kind of a monster in this world of pigeon breeders and people who feed pigeons that we need to kind of remember when we read the lung scans. And this classically falls into this bucket. Finding suggestive of another diagnosis. This is alternative diagnosis. This we are not calling UAP, we are not calling probable UAP, we are not calling indeterminate for UAP. And all these things are cysts, mosaic attenuation, predominant GGOs, micronodules, consolidation, perilymphatic or right, then CTDs. All this I have told you, these are inconsistent with UIP. So we talk of them separately. Add to this list sarcoidosis and chronic HSP. That is very important. And these days, the terminology we use for chronic hypersensitivity pneumonitis is actually fibrosing hypersensitivity pneumonitis or fibrotic hypersensitivity pneumonitis. Smoking related ILDs, I just need to briefly mention there is respiratory bronchiolitis, there is RBILD, and there is RBILD fibrosis. So, respiratory bronchiolitis is only the presence of small nodular densities. RBILD is when it is associated with reticular opacities, and RBILD fibrosis is one in which you see profound features of traction bronchiectasis and honeycombing as well. DIP is a term which we use very infrequently these days, is basically presence of only subtle ground glassing, which is considered to be the initial inflammatory response to insult which incites interstitial lung disease. And classic UIP can also occur in smokers. One last case is a 71-year-old male. There are large areas of emphysema, paraseptal as well as centrilobular, associated with fibrosing lung disease and honeycombing as we go down to the lower lobes. So, I mean, this is a mixture of findings. Do not confuse the entire disease for emphysema. Do not confuse the entire disease for interstitial lung disease. But do remember, maybe in a smoker above 70 years of age, both emphysema and ILD can coexist. And this is when we call them as combined pulmonary fibrosis and emphysema, or CPFE. Just be mindful of this entity and call it in your report. It is most likely CPFE. So emphysema of any subtype, more than 5% of total lung volume, and lung fibrosis of any subtype, if present together, it constitutes CPFE. So that basically does it for today evening. I will just introduce two small concepts to you. Done with the cases, so I'll just come down here now. So one is ILA. So this is a new terminology which has come up predominantly in the post-COVID era. It is basically a short form for interstitial lung abnormality. So what we have seen many times, that we have seen such extensive features that I've discussed with you, but sometimes we see a very small area of abnormality. It shows some amount of septal thickening. It is difficult to classify that. It is difficult to put them in together into any pattern. So either we ignore it or we call it, but just to ensure that all such cases are followed up, we started calling this as ILAs, or an area of interstitial lung abnormality. Follow up is recommended. And the next term, which is commonly used as it is our bounden duty as a radiologist, that when we see such scans, and we know that there is a scan done 6 months prior to that and a scan done 6 months before that, we should compare both all the scans. Every time if I give a report UIP, I mean, what is the information I am adding for the clinician? Nothing. I have to tell him whether the disease is increasing or the disease is static. Decrease is highly unlikely. But is the disease progressive or is it static? As an epidemiologic evidence of progression, what is extent or severity of traction bronchiectasis, new ground glass with traction bronchiectasis, new fine reticulation, increased extent or coarseness of reticular abnormality, new or increased honeycombing, or increased lobar volume loss. So basically, progression of any dimension, you have to call it progressive pulmonary fibrosis. Let the clinician know that despite whatever he is doing, the disease is progressing, and that should be kept in mind. So I think that would be all for the day, and I think I've done well on time. I finished exactly at 8 p.m. As a summary, whenever you deal with interstitial lung disease on a HRCT chest, look at the pattern, look at the distribution, look at the ancillary findings like lymphadenopathy, pleural thickening, esophagus, bones and joints. And what is important is to identify fibrosing lung disease. Remember the first slide I told you, as a youngster, if you're able to call fibrosing lung disease correctly, half the battle is won. Do not confuse honeycombing with cystic bronchiectasis or bronchiectasis. And use NSIP judiciously. That would be the take home message. And I think with that, I can stop sharing my screen.